Thank you for joining me in my next case study in this Echo Education series. Today we're looking at secundum atrial septal defect patient. With secundum ASDs, approximately 2,000 babies are born with an ASDs. They are considered one of the most common congenital abnormalities that are picked up in adulthood and account for approximately 10% of all congenital lesions. Of course, the most common would actually be the bicuspid aortic valve, though. There is actually a female predominance with ASDs, where 65–75% of patients are actually females. The complications of an ASD include such things as pulmonary hypertension and the various arrhythmias, and right-sided heart failure and right ventricular dilatation. The case study today is a female around 30 years old. She initially presented for an echo after an ASD was identified as overseas, and she was looking at getting a closure done. She did have some dyspnea, but otherwise was well. The assessments, including a toe, deemed she was suitable for a device closure, and a 26mm Amplatzer device was deployed. In the peristernal long axis view, we can see a good contraction of the left ventricle here, but when you look immediately, you can see this relative cavity size of the right ventricle relative to the left is increased. And similarly, when you do measure, it's quite a small to normal size left ventricle. She was only a small woman. But when you look at the size of the relative right ventricle to the left, you can see it is dilated. Tilting over to the RV inflow view, you can see the diameter across the right ventricle is quite large in that view. And she has trivial tricuspid regurgitation, but looking at the velocity through the tricuspid valve there, you can see it is increased. It does have some mild pulmonary hypertension. As you're tilting over, we do start already getting suspicious of some flow coming up through here. And when we tilt across, we can actually see this relative space in the atrial septum just there. And we can see the coronary sinus above it coming into the right atrium. And when we look at the diameter, that's close to 2 centimeters in width. And the looking colour flow is similar diameter. And just zooming on there, we can see that defect quite clearly. Looking at the pulmonary valve here and the main pulmonary artery, you can see some additional flow going through there, but of course you expect to have a higher VTI through the valve there, given the additional flow going through the right side of the heart. So looking at the short axis view, just below the level of the aortic valve, focusing on the atrial septum there, it doesn't appear to not be intact in that initial view. But as you tilt across, you suddenly can see that flow coming up very nicely through the defect into the right atrium. And zooming up, and again with the colour flow, you can see very clearly. And getting a slightly lower diameter than before. As we look at the short axis view, go back there for a moment, we can see some D-shaped septal flattening in diastole. And so as I just slow that down, you can see as the cavity goes out, there's just a relative degree of flattening going there, consistent with RV volume overload. Now when we do go to look at the four-chamber view, we can already see a significant increase in size of the right ventricle and the right atrium relative to the left ventricle and the left atrium. And similarly as well, the volume shows a significant difference between the sides in terms of the atria. So looking at the atrial septum there, you can see again that flow going across there. And tilting over to show the right ventricle more clearly. And we're getting a diameter of 5.3 centimeters across there, so quite a significant right ventricular dilatation. The function still remains quite good though. And here view just tilting a slightly abnormal view in terms of halfway between the long axis and the four-chamber view, but it shows the atrial septum quite clearly there, so it's a view focusing on the atrial septum. And from here we can very clearly see the significant degree of shunting going on. And just zooming on that. And again, getting a width close to 2 centimeters across there. And the dual view often will show this quite nicely. And this is just a last view just to show this actually from the right parasternal view, which is sometimes a view underutilized in terms of assessing atrial septal defects, where again it's quite nicely in line of the actual septum there, and so you get quite a good view of the flow going across. The following images are a few months following device closure. So we're looking at the first view here. The RV function looks really quite good there. Still looks a little dilated in this view, but not quite as big as it was before. When we tilt across, we can see that device looking rather large as across the septum there. And zooming up on it there, we can see it quite well. Looking in the short axis, we've lost that D-shaped septal flattening I was referring to before, but the right ventricular size as it curves around the left ventricle in this view does not look particularly dilated at all. And now when we come down to the 4-chamber view, yes, we can see the device clearly there, but the size of that right ventricle in comparison is dramatically reduced and normalized. And so if we measure that diameter across there, we'd see very quickly, compared to that size we had before, it has significantly reduced. Given we had about 5.5 centimeters, now it's quite within that normal range now. Thank you for watching my latest in this Echo Education series. I'm Marcus, Senior Sonographer from the Melbourne branch of Cardiovascular Services. Thank you again.